Hi, I'm John Davis, the Director of Client Services. We are working on getting some awareness with the Ethics Committee, just so that you're aware of the Ethics Committee. And we've asked to have a guest speaker come and talk with us today, who is with the Alberta Health Services Central Zone. She's a clinical ethicist. Her name's Victoria. So I'll just hand over the microphone to her, and then she can kind of talk about some of the frameworks that we're going to be using. Thanks so much.
Thanks, John, and hello, everyone. Welcome. It's really nice to be asked to speak with you today. I've spent the morning in your beautiful building, so I'll try not to hurt anyone while I'm up here. So really nice to be with you today. Thank you all for coming. What I'm going to do today is a collection of a number of things. First of all, I'm going to tell you a little bit about the ethics resources that are available to you within the Bethany group. Then I'm going to give you a bit of an overview of ethics. So when we talk about ethics and we talk about values, what is it that we're really talking about, and how can that help you with your work? And then what we're going to do is to apply that knowledge to a case study of a client in a residential facility using illicit substances and how you might respond. So what we're going to do is work through an ethics framework based on that case study to help you realize how you can apply an ethics framework to help you figure out a resolution to that scenario. So if that sounds okay. Okay. So, okay. So that's what I just said, so I'll keep going. Okay, so first of all, in terms of what resources exist for you within Bethany, there are two policies that exist that discuss the ethics services that you have and the resources that exist to you in Bethany. One is an ethics management policy, which it talks both about codes of ethics and codes of conduct, and also about the ethics committee and how ethics can help resolve some of these issues. So those are policies that you can look up, and they describe a little bit about the management resources, and then also the ethics committee terms of reference are posted that explain what the role is of the committee and how they work. There are two forms that exist that you can access on SharePoint or by contacting the executive assistant at the number on the screen there. And these are forms that you would fill out if you had an ethics question. So normally the process is that you would speak with your manager and try to get assistance within your existing resources or within existing policy. If the situation was more complicated or it wasn't addressed in existing policy, or there was significant consequences to the decision, like it seemed to quite a high stakes situation that may impact on Bethany as a whole, this might be a situation where it would come to the ethics committee, and they would address that situation and work through it using a decision-making worksheet, which actually parallels the framework that we're going to be talking about today. So what we'll be doing today is, in a way, how the committee would respond to your question when it was brought to them. So the committee has three main areas that they focus in, three main roles. One is representing the patient's perspective in decision-making, along with providing advice with regards to policies that do have some kind of impact on client care. The other is education. So what kind of education do care providers, patients, or families need to do their jobs with respect to ethics, and also providing advice to senior leadership about what the education needs are of staff. And the third is situation response, or what you might be more familiar with as knowing as ethics consultation, which is responding to a certain situation that has arisen where there seems to be an ethical issue where some involvement from the committee would be helpful to have a multidisciplinary perspective to evaluate it and to help provide some guidance on that situation. So in terms of when you might request a consult, there are many situations that come up in healthcare that produce uncertainty or disagreement, where you might not be sure what the right thing is to do, or there might be some gap in policy or guidelines where there isn't any clear guidance from Bethany for you to follow. So any of these situations might be when you have an ethics issue. Many of these you may be able to address yourselves in the context of your work or in discussion with your manager. Again, if it doesn't seem to be addressed in those avenues, it is something that can be brought to the ethics committee, and they can help you work through that. Okay, so what we're going to do now is to talk about what we mean when we talk about ethics. And if you brought it, so what are the kinds of issues that would come to an ethics committee, and why that may be helpful to you, and then what they would do with that. So how would knowing about ethics or thinking through ethics help you figure out what to do in a specific situation? So I'm going to give you an overview of ethics in general, and then we're going to apply it to a specific clinical case. Okay, so the first question is, what is ethics? And just because there are a couple of people in the room, quickly, does anyone want to just throw out what your thoughts are about what ethics is, what it's about when we talk about ethics? Mhm. Yeah, great. So essentially, exactly, we're going to be focusing on basically how do we figure out the right or the good thing to do, and I actually won't use it because they're recording, but talking about a dilemma, meaning usually when I talk about dilemma, it means there's some values that are in tension. So usually if we can't figure out the right thing to do, it's because people think that different things are important and those values are clashing. So what we would do from an ethics perspective is to identify what those values are and then help people work through that conflict. So here's an example of the kinds of ethics questions that would be addressed by an ethics committee. One is often around what we would call sort of unsafe discharges, or when a client or resident wants to leave the facility or wants to go home, or somewhere where you feel like as a healthcare provider there aren't good resources to support them, or you don't feel that they'll be safe or do well in that facility, that may be an issue where there's some tension. Other is around aggressiveness of intervention. So what are their goals of care around their stay with you? And when would we provide very interventionist treatment versus other kinds of support? Others are just around conflicts of when you feel, because of your training, to promote the best interests or the well-being of your client. Sometimes clients will have other things that are more important to them, and they won't agree with what you're suggesting for them, or won't be willing to go along with what you're suggesting, and that can also cause some tension for you as a care provider. And the other example up there is, because you all work in communal facilities where you have lots of clients living together, there may be situations where you feel like this client has certain kinds of needs, or you're spending certain amounts of time or resources on them that you may feel some distress about based on how that weighs up against the time or resources that you're spending on other clients. So how can you kind of make the distribution of money or resources or your time, how you can make that fair? Does some of those resonate with you in your work, or feel like the kinds of situations that you face? And some of those you may have sort of standard ways of dealing with, and other times it may seem that it's really complex and you have a really hard time, and it feels like there are some high stakes where you might request some extra help. Okay. So here's a little cartoon. The first is a healthcare provider in Canada checking a patient's vital signs. So, looks good. His pulse is good, blood pressure good, temperature good. And the same care provider in the States, doesn't look good. His Visa is no good, MasterCard no good, Amex no good. So this slide's just trying to represent that when we have, that our behaviors, how we act, reflects our underlying values. So when behaviors seem to conflict, or we can't agree on the right behavior, often that is because there are different underlying values. If you think of, people often use the iceberg analogy of what's above the water and what's below the water. You can think of the actions as being what's above the water, what you can see, and the values as being somewhat below the surface, where they're influencing the actions, but sometimes it can help to shed more light on them and figure out what are really the values that are at play. So where do our values come from? Experience? Upbringing? Society? Yep. The church? Yeah. Religion, for sure. Media? Your profession? Yeah. What you've been trained to believe? Yeah. Or what you're committed to as part of your profession? And often our professional values, we kind of learn those when we're going through that training. What we find, though, is some people's values get formed starting from very early on. So how your parents teach you to share toys with your brother, say please and thank you is kind of etiquette. But the right idea is we get sort of taught about the right way to behave sort of from a very early age. And some of these big influences are exactly the ones you mentioned. So religion. So what people's beliefs are about the existence of a deity or spirituality, what's important to them holistically, that can affect things like their beliefs about what's important in their life, what their beliefs are about death or the dying process will be affected by if they have belief in an afterlife, or what the meaning of that is described as being in their religion or their faith perspective. Culture here includes family, ethnicity, our upbringing. So what are the experiences that shape us as we grow up that will affect the things that we believe to be true and the things that are important to us? And then thirdly, the society. So this includes the media, our legal system, our political system, all of those other contextual factors that influence what we believe in our society. So what this slide also implies that depending on your different beliefs or your different contexts, you may develop values that are different from other people, which in some sense is at the root of why we have tensions in value with other people, or why we might have some disagreements on how to act in certain circumstances. What we try to do from an ethics perspective, and what the ethics committee would endeavor to do when addressing your question, is relying on ethics sort of guiding principles that have been developed over time to try to help guide behavior that's been generally regarded to be acceptable in a multidisciplinary, multi-ethnic cultural perspective, meaning knowing that people have different values, how can we rely on ethics theories that are generally held to guide our behavior to help us figure out what to do? So basically some common understandings of ethics. So that's what we're going to move to next. So there are some key ethics principles that some of you are probably familiar with. I'm just going to put them up there. Do these sound familiar probably to some of you? So these are mid-level principles that are usually taught to healthcare providers. Autonomy generally means I don't know if I have that. Oh, I put them up there. Isn't that convenient? So, so the principle of respect for autonomy usually refers to the idea that rational human beings have goals for their lives, have ideas about how their lives should go, and therefore they should be included in decisions that are made that will affect their lives. So this is why we care about things like informed consent and involving clients in decision making, because they'll be experiencing the consequences of that. And we want to make sure that if they have values or things that are important to them, that we're taking that into account. Beneficence is maybe kind of the core, what many healthcare providers are trained in. This is just the idea that your job is to promote well-being for your clients, to try to improve their quality of life, to try to help them feel better, be better, not in a moralistic way, but just to help them do well in their lives. Non-maleficence is the sort of the flip coin of that, which is trying to avoid or minimize harm for your clients. Often people put these two together, beneficence and non-maleficence, and talk about that in terms of best interests, right? Which is just basically weighing the harms and the benefits and trying to make a decision where the benefits are outweighing the harms. And then justice, this is when we talked about treating people fairly, these are concerns about justice. So this is sometimes defined as treating like cases alike. So if people come in fairly similar circumstances with fairly similar issues, they ought to be given a fairly similar response in return. If they get some widely or different response, often that would raise concerns about discrimination, or if they're somehow being treated differently in a way that we wouldn't think was justified. This can often also be defined as a fair distribution of resources. So resource allocation questions would also fit under justice. How are we dividing up what we have in a way that seems to be fair given the people who are receiving the benefits of those? Okay. So these are mid-level principles. So these are drawn from larger ethics theories, but the idea is that these are principles that are more easily applicable to healthcare And they're things that can guide us, and they're principles that are widely and commonly accepted in Western healthcare and Western society to guide action. So even though people may have lots of individual personal values, these principles are held to be important as guides in healthcare. But like I said, they're drawn from larger ethics theory, and there are other theories out there. So what I'm just going to go through is I'm going to walk you through a little bit of a thought experiment about the theories that these are drawn from, and then what some other things are that we might want to think about in ethics. This requires a little bit of participation, but it's recorded, so everyone who's watching this recorded later has to participate on their own. Okay. So a thought experiment, I don't know if any of you have ever done thought experiments before. They're tools used by philosophers mainly, and they're designed to be extremely artificial, black and white scenarios that force you to make a decision one way or the other. So there's no way out of them. You can't change the scenario. You can't make any variations. You're forced one way or the other. And the point is to try to test your moral intuitions. Okay, so we're going to start with what are called the trolley experiments. Okay, so that's a picture of a trolley in case you don't know. These are old thought experiments. That's probably not the trolley. I think this is from Toronto or something, but it's probably not the thought experiment or the trolley that they had in mind originally, but okay. So we're going to start with a thought experiment that looks like this. You have a trolley that's hurtling down a railway track. And tied to the rails in front of this out-of-control trolley, there are 5 people tied to the rails. If the trolley continues on its course, it's going to hit and kill those 5 people. However, for reasons unknown, you happen to be standing next to a lever by a junction. And you have a very few seconds to decide whether you will pull that lever and redirect the trolley towards the other rail, which has 1 person tied to the track. If you pull the lever, this 1 person will die, but the 5 people will be saved. So all of you in the room and all of those watching the recording, I'm going to give you 5 seconds, and you're going to raise your hand if you would pull the lever to redirect the trolley towards the 1 person rather than the 5. So raise your hand if you pull the lever in 5, 4, 3, 2, 1. And then there are always the people who are like, I'm going to pretend I'm not here. Yeah, so for those of you on the recording, I would like to know what you did with your hand. For those in the room, most people raise their hands. So most people raise their hands in this scenario. Why? Why would you pull the lever? Pardon? Doing the least harm, right? Anyone sort of feeling the same? So that's how most people describe this. Doing the least harm, minimizing consequences. 1 person is dying instead of 5. So purely based on a numbers game, that seems better, right? So that's the justification that most people will give. So that explanation, that intuition, represents an ethics theory called consequentialism. And that is a guiding principle meant to reflect all of our moral decisions, where the definition of a moral thing to do or the right thing to do is that which has the best overall consequences. So the most common form of consequentialism is called utilitarianism, which is to do the greatest amount of good for the greatest number of people. So beneficence and non-maleficence are both mid-level principles. So mid-level because they're between the big ethics theory and your frontline cases. Beneficence are both done from consequentialism, meaning you're looking at the consequences. What's causing the most benefit? What's going to cause the most harm? How do we cause the most benefit over harm? Make sense? Yeah? Okay. So now we're going to change the thought experiment. In this scenario, you still have the same trolley hurtling down the tracks, and you still have 5 people tied to the rails. However, there happens to be a bridge between the trolley and the 5 people tied to the rails. And you, for, again, reasons unknown, happen to be standing on this bridge next to a very large man. And you have to make the decision about whether you're going to push the man off the bridge onto the tracks, where he will then stop the trolley. He will die, but the 5 people tied to the tracks will be saved. And just so you know, it is a thought experiment. You yourself cannot jump on the bridge. You will not save the trolley. He's not going to volunteer to jump off himself. There's no other way to make this a more pleasant example. So you have 5 seconds to decide whether you're going to push the man off the bridge to save the 5 people. So I want to raise your hand if you're going to push the man off the bridge in 5, 4, 3, 2, 1. A couple of people raise their hands. I don't know what you did at home or in your facility, but very much fewer people, many fewer people will raise their hands to push the man off the bridge. So those of you who pulled the lever in the first scenario, but would not push the man off the bridge in this scenario, why not? So the response is you can't be God and result in someone's death. Exactly. So then I would ask you, yeah, how are you not being God by pulling the lever? Yes. You do know because I've told you. It's the thought experiment. It's the constraints of the thought. He will absolutely die, stop the trolley, and save the 5 people. Yeah, you had 5 seconds. And why do we care about murder? So this leads me to my comment. Um, so that was meant to be a rhetorical question. We do obviously hear about murder, which is part of the point of the thought experiment. So in the first scenario, most people, and when these thought experiments are done internationally through people of different ethnicities, different cultures, different ages, every different kind of variation you can get, the numbers and responses are pretty much the same. It's about 93% or something will pull the lever, and 18% or something will push the man off the bridge. So what you did in this room is very representative of studies all around the world. However, from a consequentialist perspective, these two thought experiments are exactly the same. Based on consequences, in the first one, 1 will die and 5 will live. In this one, if you push the man off the bridge, 1 will die and 5 will live. If you are purely looking at the consequences of your action, these are the same. The fact that people's responses are so different, and if we had more time, this is more interactive, and I didn't feel bad for people on the recording listening to silence as we discussed it in the room, we would have more discussion about why you think there's a difference here. But the fact of the matter is, there clearly seems to be some kind of a difference. And so what I would say to respond to that response is to say that that is because as human beings, when we are thinking about what's important in our moral lives, we obviously don't just think that consequences are important. Right? We're obviously relying on other things in our moral decision making that makes this scenario different. So how this scenario is different is reflective of a different kind of ethics theory called deontology, which means the duties that we owe people. What do we owe people? And this is where the comment about feeling like you're killing somebody, why this comes into play. Because this theory talks about how there are certain things that we owe people just by virtue of them being human beings. By recognizing that they have rationality, that they have plans for their lives, that because we want that respected in ourselves, we need to respect that in other people. So the most famous deontologian, if that's a word, deontologist, is Immanuel Kant. He's a philosopher. In the way that he framed this ethical principle, he had 3 formulations, but the one most relevant to this one is that we can never treat other human beings merely as a means to an end. We have to treat people as ends in themselves. So there are people that we treat as means. So healthcare providers, you're providing healthcare service, but you're also human beings. So your hairdresser, you treat as providing a means to an end. So you're using them to provide a service, but we also need to respect people as humans in themselves, as having goals and ends in themselves. So the reason that explains this thought experiment is that by pushing this man off the bridge, he's being treated merely as a means, as a way of saving 5 people, but he is not being respected as a person in himself. So that's where these 2 mid-level principles of autonomy and justice come from. So autonomy means we need to respect people, what's important to them in their own lives, whatever the consequences sometimes. So for example, It was often a difficult situation in healthcare that arose with people who have beliefs of Jehovah's Witnesses who didn't want blood transfusions because it conflicted with their spiritual beliefs. And often refusing a blood transfusion would mean that they would die. Right, but respecting their beliefs is generally thought to be important because it has to do with their beliefs in their faith, their beliefs about their afterlife, that is more important to them in many circumstances than their physical health or longevity, right? So in that sense, respecting their beliefs is important, and it's different from just focusing on consequences. And similarly with justice. So while if we focused on the consequences overall, we would do things like push people in front of trolleys to save other people. But we actually care not just about overall numbers, but on how those goods are distributed. So while that might be good overall for the number of people in that scenario, it is very, very bad for the man who got pushed off the bridge. Right? So we care about that. We care about how people are being treated within our society and within our healthcare system. Okay. So those are two big ethics theories, deontology and consequentialism. There are there's other theories that criticize those and who focus on other things that we think are important. So to illustrate that, we're going to go back to the first thought experiment. So this is the one with the 5 and the one with the lever. So think back to that one and think back to whether you would pull the lever or not, what you decided in that scenario. But in this experiment, this thought experiment, the one person tied to the rail is your brother, daughter, mother, cousin, grandfather. So now how many of you are going to pull the lever? Surprisingly few people will pull the lever in this scenario, which from a consequentialist position is irrational. So what this shows is that as this is reflective of other theories that focus on the fact that those other two theories are very rational, rationality-based, based on duty, based on consequences, number calculation, and they ignore a very significant aspect of our moral lives, of how we make decisions, which is based on the fact that we're in relations with other people. We actually are partial. Human beings are partial. We care about people. We're in relationships, and that actually does affect our decision making. When people are making decisions about where they're going to live or what supports they need, it's going to be affected by how it's going to affect their loved ones, how they're going to be able to continue with their relationships or the activities that they enjoy. All of those things will be taken into account. So that reflects two ethics theories that came about through feminist theories, which is basically paying more attention to how we are in relations with others. So care ethics is a theory that focuses on the relations. So as human beings, we're all in relations with other people. And they argue that what's important, what is the right thing to do, is that which preserves relationships. So you're in relations with your clients. They have relations with the co-residents and their family members and others. How do you acknowledge, respect those relationships, maintain those relationships, and respond to the needs of the person you're in a relationship with? And sometimes, and partly the discussion around that is if you're damaging relationships or people don't feel like they're continuing that relationship with you, that has an effect on things like how they can make decisions with you or how you can support them in decisions, whether they'll be accepting of healthcare services. It can affect kind of a number of other things in healthcare. And relational ethics points to a sort of a broader understanding of how our decisions are influenced by our broader context. So the reason that relational is overlaying autonomy and justice is because it can apply to both of those. So there's relational autonomy that says things like how free we are to make decisions that matter to us has to do with all kinds of things brought beyond our control. So the decisions that you make about what healthcare services you want is affected by what the society thinks is important to spend money on, so how resources are allocated, what conditions are studied and researched, which affects what drugs are available, which affects what decisions you can make about drugs you want. All of those decisions affect our ability to enact our own autonomy. And it also pays attention to power dynamics and power differentials. And that's really important for care providers because you're always in a power dynamic situation with your clients because all patients, clients, residents primarily when they're very sick. But regardless, they're in many ways dependent on you as care providers. They're sick, or they're in need of your expertise, or in need of the resources that you can provide. And so they're always in a position of vulnerability. Whereas you're in the position of having that expertise, having the access to the resources, and having the ability to provide those to them. And that can also affect how free people are to make decisions. If they feel like they're being asked something that will affect how they're being cared for, how they're treated, it will affect how free they are to make that kind of decision. And relational justice, that points to the fact that there are power differences between social groups. This can be based on things like stigma, historical discrimination, things like colonialization, things that actually affect how fairly people can be treated in our society. So to make that a little bit more clear, I just have a little cartoon. So this shows 3 boys watching a baseball game over a fence outside the park. And in the first one, we have the tall, middle, and the short boy. They each have 1 box. So this illustrates treating people equally and that everyone gets a box. What we care about in ethics is not everyone being treated the same, but people being treated fairly, which we often use the word equity, which takes into account the disadvantages that people are already starting with, what their needs are. So in this situation, we have height disparities, and we have one particular boy who's incredibly height disadvantaged, and others who aren't. And in that distribution of goods, it seems more fair for the littlest boy to have 2 boxes and the tall boy not to have a box at all, and that way they all have the equal opportunity to watch the game. And that's what we strive to do in healthcare. So in emergency, we triage, right? So people are given resources or access based on their needs. And we do the same thing throughout. And this can sometimes mean that people with higher degrees of needs or more significant disadvantages that they're starting out with have a claim on more resources, which can mean making extra efforts to provide those services, which could include, for example, bringing in an interpreter for a client of a different ethnic background who doesn't speak English. So it's maybe more work, it maybe takes more time, it's maybe more awkward, but they need that extra service and that extra time in order to have the same opportunity to make an informed decision about their healthcare as another client who may speak English. Does that make sense, people? Okay, so that is relationship. Okay, so all of we've talked about so far is all based on action theory, which is how do we figure out the right thing to do, right? The right action to take, the right way to behave. So for the first 2,000 years of moral philosophy, no one actually cared about that question at all. So everything we've done so far was irrelevant. So the philosophers that you have up here, Plato, Socrates, and Aristotle, which I'm sure are people you think about often, what they cared about, does anyone want to guess? Not enough Aristotle for you? That's what they cared about is what does it mean to be a good person? They felt like if you developed the right sorts of characteristics that lended you towards sort of the end of being a human being, the correct path of a human being, you would just naturally make better decisions. And so that wasn't the thing to focus on. The thing to focus on was what were the inner characteristics, the character traits that we needed to develop in order to be better human beings. So this is called virtue ethics. It's the oldest ethics theory, and it's been adapted to healthcare to say what are the virtues, what are the character traits you need to be a good healthcare provider. And the end or the goal of a healthcare provider has been defined, at least by Edmund Pellegrino, who adopted this for healthcare ethics, as health, healing, and caring. So that's the goal of a healthcare provider. So what characteristics do you need to be developed to achieve that end? This is called virtue ethics, and there are a number of virtues that he proposed. One, which actually isn't his, but I think it's important and people relate to, is being compassionate, having compassion. So if you were, let's say you were a nurse, and you followed all your procedures and you did all the right things and you could measure the medications and monitor the patient and you were excellent at all the skills involved in being a nurse, but had no compassion towards your patients, do you think that that nurse would be the most excellent nurse, or there might be something lacking there? So it's thought that these character traits have a really big influence. Others of these include the virtue of fidelity, which means trustworthiness. Because if you aren't a trustworthy person, your patients who need to rely on you and give you sensitive information, tell you about private things that they wouldn't tell their neighbors about, like their bowel movements or their pains in various parts of their body, aren't going to want to share that with you if they can't trust you, if they don't think you're going to use that, keep their information confidential, use it to promote their best interests and that kind of thing. So trustworthiness is really important. Prudence is another. You might want to reframe it as having good clinical judgment. Because if you don't have this, then even if you thought about all the other values that we've already talked about, if they came into conflict, how would you know how to figure out what to do? So having good clinical judgment is a way of helping you figure out what to do in those situations. So that's kind of my summary of 3,000 years of ethics theory. I don't know if anyone had any questions or wanted to ask anything about those. These will then ground the values that we look at when we apply an ethics framework to a case. So, so I think they'll become maybe more clear as we work through them. But these are kind of your foundation blocks for doing ethics analysis. Okay, and so why we have all of these? So for a lot of years, people tried to develop the one guiding principle that would help us figure out what to do in any situation. But what we found were there were some disadvantages and advantages of all of those. And so what we do from an ethics perspective is kind of take them all into account and then see which ones are most relevant in a certain circumstance. And that's because every ethics theory focuses on a different part of an action. So this is a little illustration as the person trying to make the decision. Then you have the action or the inaction, doing this or that, and the consequences of that action. So consequentialism, that ethics theory, looks at which part of the moral action. This isn't a trick question. It looks at the consequences, right? Okay. So consequential looks at the consequences of an action. Deontology looks at the motivation or the intention. Remember, it says we need to act out of duty. We have certain duties towards human beings. So deontology focuses on the motivation or the intention behind the action. Which theory looks at the characteristics of the moral agent? Yes, virtue theory, exactly. So those different theories focusing on different parts of the action. And then we have the feminist theory, so care ethics, which points out that looking at this moral agent as an isolated, independent, rational decision maker is an inappropriate reflection of our moral lives because that person exists in relations with a lot of other people. So we need to take into account those relationships. And then relational ethics just points to the fact that all of this is taking place in a broader social context. And things like the law and the resources and the money and societal influences are all going to affect what actions are even being considered, what decisions are being brought up as decisions, and what the scope is of the moral agent to make that decision. So part of our conversations this morning, I was speaking with the ethics committee, and one of the issues that we talked about, which is relevant to all of you right now, is our new changed legislation around physician-assisted death. So the fact that that came up in our conversation this morning as a bit of a conversation is because of a change in law, right? So those things that happen in those other contexts will then affect what kinds of situations you as a healthcare provider might end up trying to make a decision about from an ethics perspective. So what we try to do is to take into account all of those different aspects of what's going on and then help figure out what to do. So they won't all be relevant in every situation. So you don't have to consider all of these all the time, but do a quick scan and see what seems to be the most important. And then you'll isolate a few that are most important. And those are the ones to focus on when you're thinking about a situation. So we're going to illustrate that in the case study. So we've basically been focusing on values. So how do we figure out what are the values? What are the things that are important in a certain situation? Decision-making frameworks are basically a stepwise process of trying to figure out what is the right thing to do. So first you have to figure out what your question is. What is it that you're being asked? What is the right thing to do in what context? And then what are the relevant facts? And then what are the relevant values or principles? So of the sort of the ethics series we sort of covered, of those values and principles that we talked about, which seem to be the ones that are most relevant in that context? What is your range of options? So if you're trying to make a decision, you need to figure out what your range of options is. And then which options seem to be the most justified? So which options seem to best reflect the values that you thought were the most important? And then once you decide which option seems to be most justified, obviously then you would make a decision that seems to be the situation or the option that's the most justified in that situation, and then you would make that decision and then try to learn from that. So that is essentially the framework that the ethics committee would go through when you brought a situation to them. Okay. Were there any questions about any of that before we move on? Yeah? Excellent. The comment was just very straightforward. I'm glad you think so. Perfect. Good. Okay, so this is what we're going to kind of go through this now with a case. So the case that we thought would be helpful to talk about is when in your facilities you have clients who seem to be using illicit substances. Off the property, on the property, suspected or known, and what ethical issues come up, and then how you would try to respond to those. Just as a show of hands, how many of you have had situations like this that have come up for you in your, yeah, some of you? Okay, perfect. Okay, so this is our case study. We're going to talk about Mr. D, who has a history of substance use. He sometimes returns to the facility having clearly ingested other drugs. Once, a healthcare aide found marijuana in his room. Staff members are concerned about his health and safety, primarily sometimes if the drugs might be interacting with other medications that they're giving. The safety of other residents who might maybe find these drugs or take them unknowingly, especially in care facilities where other people might have dementia or less understand what some of those substances are, and the extra time they feel like they are spending on him. Some staff members feel complicit in his drug use when the substances he seems to be using are illegal. Does this sound? Yeah. So this seems to come up a lot. I've seen it in long-term care for sure. I don't know. I'm interested if this comes up in your lodges often, but certainly in long-term care and continuing care, it does seem to come up. I'm seeing nods. Okay, so that's good. It's applicable everywhere. Okay, so this is my attempt to kind of highlight what I think the key values are in analyzing this case. So normally in ethics framework, first of all, you'd find out a lot more facts. I've given you just a little bit. And normally you would want to find out a little bit more. So what is his medical situation? What are the issues actually arising? Why are people concerned? And then really try to focus on. And then from there, you would kind of do the ethics work to figure out what the values are. And sometimes that can be the most helpful piece to do, is to use some of that ethics language. So the one thing that came up in the case study that you might be concerned about as a healthcare provider is non-maleficence. So that principle of trying to avoid harm. First of all, what is the harm that's being provided? So there is the harm of the drugs just physically on the person. Sometimes that harm is obviously of a concern. That harm often drug use is reflective of other kinds of pain and suffering in clients. So addictions are thought to be symptoms of underlying suffering. It's usually addictions are a result of toxic stress or trauma that often in childhood that affect the developing brain, and that substances are used kind of as a self-medication or coping mechanisms to the suffering that person experiences. So what is the harm of the drug to the person, and what are other harms or suffering that client might be experiencing that you might be concerned about? And the other concern with risk always to think about is how can you reduce some of those harms? So trying to reduce harm is something that you should always be concerned about as a healthcare provider, and how can you reduce some of those risks? So often in consults, I'll hear about Other concerns, like if this person comes home under the influence of whatever, that he might trip or fall or do something dangerous or somehow might harm himself, in addition to what reactions this might have to other medications. Some concern that he might harm others. Sometimes this results in staff finding drug paraphernalia in the patient's room, which could harm him, maybe could harm others. And some things we talk about a lot in healthcare around addictions is harm reduction. I don't know if people are very familiar with harm reduction. I brought Alberta Health Services policy on that and left it at the back of the room, and I believe it might be attached as a handout to this recording. But essentially, harm reduction is a strategy which says it acknowledges that while you might feel inclined and always want to be available to try to help somebody address drug use, that it's acknowledged that this may not be possible for all people, that it may not be possible for them to stop their substance use. So the goal of healthcare providers is to try to reduce the negative consequences to them of their behavior. So harm reduction is agnostic towards the morality of the behavior. So it doesn't judge the behavior, but what it says is we acknowledge that this is happening. We want to make it as safe as possible for people. This, you may be more familiar, this is the philosophy behind things like safe needle exchanges or methadone clinics, right? You acknowledge that people will be using drugs, so you want to at least try to prevent the spread of infectious diseases or infections or the things that you can do to actually make sure it's as least harmful to them as you can. So various of those techniques might be discussed here. We can talk about some of those. Fidelity I bring up as one of the virtues that we talked about. I often get consults from care providers this happens primarily in long-term care, where staff say they're going out and they're using this, that, or the other, we don't really know, and then they're coming back in and asking for their pain meds or their whatever meds, and I'm worried as a healthcare provider that I'm going to cause them to have some kind of a reaction. And so one way of trying to reduce negative consequences is to see if they would trust you to tell you what they're taking so that you can make whatever adjustments might be necessary to their medications. But they're not going to tell you that if they feel judged for their behavior. Right? So that's one of the things where the trustworthiness will be important to try to reduce that harm. What we find often with healthcare with the use of drugs is that people's control over their drug use, people's control over any decision they make in their lives along a continuum, that it's maybe not 100% in their control or zero, but somewhere along the road. And if 100% of the control over their behavior is assigned to somebody who has substance use problems, there is then a tendency to blame that person for their behavior and for their choices. And that can have detrimental effects on the therapeutic relationship. Okay, because you don't empathize with them anymore. You don't sort of you don't see their suffering in the same way. So being trustworthy is a way of trying to see where they're coming from, see if you can establish a relationship with them, and then that can be a way to try to reduce some of that harm. Liberty is one of the values that we talk about. We didn't talk about this in the ethics theory, but it's sort of related to autonomy. The idea that people should have the freedom to do what they like. Autonomy talks about more deeply held values and beliefs, but generally, so liberty is related. It just means people having the freedom to live their life how they choose. And generally, we are not too interventionist in our society. There's usually more tolerance. Actually, that's a different, I won't say it, but anyway. The father of libertarianism is John Stuart Mill, and he famously quoted that my freedom to swing my fist ends at your nose. So the idea is we don't want to interfere too much in people's lives. We want them to, we should let people do what they want to do until it gets to a point where they're restricting the liberty of other people or they're harming other people. Then is when we might want to intervene. If we do feel like we need to intervene with somebody's choices or somebody's actions, then it's thought that we should try to intervene in the least restrictive means possible that's necessary to try to prevent, let's say, harm to others. Consequentialists, again, we're looking at our overall consequences. So especially if you're working in a communal facility, it's important to look at what the broader consequences of this will be. Do you have a policy? How will it affect the policy if we make certain kinds of choices here? Is it affecting other people in your facility in a negative way or otherwise? How is it affecting your staff? All of that would be things you would want to keep in mind in a general kind of broad look at things. One thing is important to think about in terms of consequences is when we're talking about harm, there's sort of a range of different factors we might want to take into account. So there's the likelihood of the harm occurring, and there's the magnitude of the harm. So how serious would the harm be? And this is relevant because sometimes people talk about risk really broadly, and it's not clear what exactly the harm is. And that would be really important to try to think about. And it's kind of related to the last point about social justice, which is about the concern about particularly stigmatized or marginalized populations. Because often what I will hear, I often get consults about people who are in facilities where staff want to restrict visitors because they feel like the visitors are bringing in drugs, or they look all unkempt and they make people uncomfortable, and they feel like they're making other residents uncomfortable. And so one of the questions I always ask is, because the worry is that they're harming others or they're a risk to their other patients, which is a legitimate concern, absolutely. And so then I'll ask, well, what kind of harm are they aggressive towards people? Have they made threats towards people? And that's, I think, important when you're trying to weigh what the harm is to others versus how you might be justified in restricting somebody's liberty, is to pay attention to what that harm is. Because often what I get back is, oh no, they've not been aggressive. Oh no, they've not done anything, but they make people uncomfortable. And I say, well, uncomfortable is not necessarily a harm to people. So you just want to kind of be specific. And the reason that I ask those questions is because of the concern about social justice, which is that because there are certain conditions in healthcare that are particularly stigmatized. Obviously, addictions is one of them. Mental health is another. Infectious diseases are another. When people and it can affect how people are treated. So when AIDS was at first became huge, was a really big issue in society, it mattered how people got it. Like in the 80s, if people got HIV because of a blood transfusion, they were treated very differently than if they got HIV because they were in a homosexual relationship. So so those are the conditions we just need to be aware of, that those are stigmatized conditions, and we need to pay special attention to make sure that these clients are being treated in a way that's fair and are being treated in a way that other patients might get treated in those contexts. For example, the visitors to your other patient in your other bed who come in with business suits are just as capable of smuggling in drugs as the people who coming in looking like they're sleeping on the streets. So it's important to pay attention to that. This also comes up in terms of the concern about spending more time on patients. Usually the patients who have significant alcohol use, drug use, even smoking, staff often are concerned, including managers, that they spend so much more time worrying about this patient or trying to figure out how to respond to this client. And that may be true, and it may be justified because of the stigma, or it may actually be that not that they're objectively spending more time, because they may be spending lots of time doing care for their paraplegic patients, the people who need all kinds of wound care. It's just that the time spent with this patient seems less valued, because we think they could make different choices, or they don't really need to be here, or they should be somewhere else, or they should be somewhere with people with different kinds of training. So that's just something to keep in mind too, whenever you're dealing with anyone in a stigmatized or marginalized population, to make sure you're taking that into account. Okay, so that was a kind of range of values that might be relevant. So at this point, then I would ask you to brainstorm options. So what is the whole range of options that you might think of? I welcome feedback from the group. I threw up a bunch on a slide just because it's being recorded, and I wasn't sure if I'd be able to think them all off the top of my head. But these I just wrote down off the top of my head. So these are some things that people think of. And again, the brainstorming of options isn't necessarily what you think is the best option, just what is your range of options? What are all the things you could think of that you might want to consider? Some people think they just shouldn't be in the facility. they should just be evicted. Other people think we just need to make sure they're not using those drugs in the facility so that other patients can't have access to them. So as long as that's not happening, what they choose to do off grounds is up to them. Some people may feel like they have an obligation to try to intervene with their drug use for their own health, for their own well-being, and that's part of their role as a healthcare provider. Others may feel that they have a role to intervene because of legal requirements. If it's illegal drugs, that they feel like they need to report them to the police. So these are sort of a range of options. I would like to hear if you have other thoughts, or we could talk about this at the end. So we can have further discussion, but this is by no means comprehensive. But this is where you would think, broadly, what are all the different things you could do? And this is where there's a lot of scope for creativity. People come up with very interesting compromises and ways around some of these issues. And what you're trying to do, what I've kind of written here in brackets, is you're trying to see how those different options reflect the values that we identified on the last slide. So if, for example, you were thinking about the value of whatever he does off grounds is up to him, but he can't use anything here, that's a bit of a compromise with liberty, right? So we are not sort of intervening off grounds, but you are intervening a bit while he's here, and that may have a role in protecting other residents, which is also part of your obligation. Some may be more restrictive of others, so then you're placing more weight. Let's say there is significant harm from his use if he comes back under the influence, that he is causing harm to others, then you might think of other ideas that are more on the side of preventing harm to others, which would justify restricting his liberty more. So all of your solutions will weigh those values differently. So part of your job and part of the role of the ethics committee would be to consider those options then and weigh them against those different values and try to figure out which option best reflects the kind of totality of values that you thought were important. And sometimes that's creating your best compromise. Sometimes you can say more clearly, oh, this is definitely where we need to go. Some of the things to keep in mind when you're evaluating your options. So now, after you've brainstormed your options, you want to see which options seem to best reflect the values that you thought were important. So when is just your main ethics conflict is the values of liberty, which we think are very important in Western society, versus the risks, right, to that patient and to your other client and to your other clients. So what actually are the risks? How significant are they? Who's at risk? What is the severity of those risks? So it's important to identify those and then figure out, is there any way to mitigate those risks? Are there any strategies that you can implement to help reduce those risks for that patient, which is the harm reduction approach, and for your other patients? How can you sort of keep people safe? And there's a way to do that with sort of different impacts on liberty depending on what you do. The other thoughts around your legal requirements. So I'm interested in the thoughts around the lodge, actually, but generally for healthcare providers, the argument in terms of what your obligation is to uphold the law is to feel like healthcare is actually a very different endeavor from the legal system. So we think of healthcare as being a social good in Canada, meaning it's a basic human right that everyone should have access to basic medical care, that's important for people to be able to do the other things that they value. That's why we have a public healthcare system, mostly. And what's important for that system to work is that the system's also non-retributive, meaning it's non-punitive. We don't punish people, generally speaking. We're not supposed to punish people for their choices. So when people come in because they've been snowboarding and they've broken their elbow or their collarbone, we don't say, well, this was your choice. You brought this upon yourself, so we're not going to be treating you. We don't do that. We treat them. They come in. We treat all kinds of people who've made all kinds of choices, which have infected their health, and is why they ended up in healthcare. So generally what we do, like I pointed out before with the triage, we assess needs. We treat people based on their needs, and we respond in kind. So we don't provide healthcare based on personal characteristics, based on likability, based on personal hygiene, based on personality traits, all the things that we notice and they may bother you in healthcare. They may be things that come to your attention, but that the healthcare is provided based on their healthcare needs. So often this is considered quite separate from legal requirements. And the reason we think about that is basically a justice argument, is that if these people didn't have healthcare needs, which is why they ended up with us, they wouldn't have that closer scrutiny on their options. So for example, the person in this house, let's say this was home care and they were living in the community, if they smoke marijuana with their friends in their house, but all the houses on the rest of their street also smoke marijuana with their friends, the fact that the people in this house, let's say, need dressing changes once a day, why should they be at increased scrutiny of having their behavior be reported on because they were involved with the healthcare field than all of the other houses? So often that's gotten around, if that's the word. People get around that in home care by saying things like, don't smoke within an hour of me being there. If there's any drug use when I show up, I will leave, that kind of thing. So there are sort of ways around that to not feel like you're sort of participating, and also to protect your own health and safety if sometimes people are more violent or aggressive with various substance use. The example I often give for this when people really struggle with what are your obligations with legal requirements is the gunshot and stab reporting guidelines. Are you guys familiar with that? It was a new legislation in Alberta, I think in 2011 or 10, which required healthcare providers in Alberta to report to the police if anyone came into their healthcare facilities with a stab wound or a gunshot wound. They made that a legal requirement. There was massive protests from the healthcare field about that. And their arguments were similar, right? They said, our job as healthcare providers is to treat based on need, right? Our job is to treat their stab wound, to treat their gunshot wound, to treat their healthcare needs. We are not an arm of the legal system. It's your job to do your investigation about criminal activities. That healthcare is not an arm of the justice system, and that if patients know that we're going to report them or call the police, they won't come to the hospital with their gunshot wound, and their health will be affected potentially, right? They may be in significant harm. So that, in some sense, what it does is it's forcing them to violate their duty of confidentiality to their patient, which can produce barriers for healthcare, especially for more marginalized people who may be in situations where they're getting gunshot wounds or stab wounds. So that's an example of a situation where the legal system has sort of interfered in healthcare, and the kind of reaction that healthcare providers feel based on that. Some of the other things important to think about are your obligations as healthcare providers. So we talked about this in terms of virtue ethics a bit, as your jobs is the health, healing, and caring. And one of the most important relationships we have with patients is what we call the fiduciary relationship, which is that trust relationship with your patients. And that's why confidentiality is so important in healthcare. And there are actually very strict criteria in law about when you can violate that confidentiality. And so that's something to keep in mind when you find out something about your patient, especially involvement in illegal activity, that when you would be obligated to breach your duty of confidentiality in order to report that, there are very strict criteria on when to do that. And the idea is we want to make sure it's safe for people to share information with healthcare so that they can get the help that they need. So that's where you might want to get some legal guidance if you're considering any kind of reporting. One of the struggles, I think, with healthcare providers around addiction use or substance use is that often healthcare providers are trained with a medical model. We diagnose, we fix, we want to cure, we want to get people better. And that's very dissimilar to an addictions model, which is more of a chronic management issue. It's very hard for people to stop addictive behaviors. I don't know, hands in the room, is anyone here addicted to either caffeine, Diet Coke, sugar, any of those substances? Yeah. How easy is it to stop? Yeah, it's hard. So they're all substances that we all use to sort of self-medicate, to get us up in the morning, to keep us going during the day, to bring us down at night. We all have substances that we use to do that, and they're very hard to change. So it's one way that's helpful to think about addictions is more of a chronic model as sort of addressing, sort of to manage it over a long period of time, recognizing that people will still use, will still relapse, and how do we support them through that. And just thinking about that goal of providers as health, healing, and caring. If you don't cure them, if they don't stop using, that does not mean you have failed as a nurse, as a healthcare aide, as a manager. If you're providing them with a safe place to live and a roof over their heads and 3 meals a day and other supports that you're offering to them, you are still helping them. They are still better off than if you weren't providing that kind of care to them. People talk about compassion fatigue. There's some really nice literature around that as people objecting to that phrase and saying compassion isn't fatiguing. What it really is, because that's sort of a natural human response, is that what's fatiguing, what that really means is attachment fatigue. Is that we get exhausted or drained when we get too attached to the outcome of our hard work. When we think this is what would be the right solution. Why aren't they doing this? Why aren't they cooperating? Why aren't they stopping to do this? Why are they making themselves worse? Why are they harming themselves? Why can't they blah, blah, blah? And it's frustrating if we're not able to accomplish that, and that can be very draining. So sometimes it's helpful to think of that, to try to figure that your job is to support and meet their healthcare needs and not necessarily to fix them of their drug addiction. You can be supportive of that. You can offer them resources to help with that. But it doesn't make you a bad healthcare provider if you aren't able to accomplish that. Although it's great to help support that in any way that you can, obviously. And lastly, I just want to point out the relationships that matter. So one is the therapeutic relationship with your client. I mentioned before that sometimes blaming patients for their choices can damage the therapeutic relationship, and it helps you disassociate, and then it can cause you to be less compassionate. And one way to help address that, to try to repair that relationship, is to try to validate their experience or find something to empathize with in their story. Usually people who have addiction behaviors have had awful trauma in their histories. There just may be things about them that you can find to like about them, a talent that they have, a job that they've had, something that you can empathize with, which will then help you to reestablish that relationship. The other is to look out for yourself. Healthcare is a tough job. You sometimes have very difficult clients. And it's important to recognize when you are feeling that drained experience, when you do need that support from the other people that you have relationships with, and to try to get help from the people that are around to help you do that, like your colleagues, your managers. In this case, if it's an ethical situation that you're trying to confront, you have the ethics committee as well to help you figure out what's the best way you might have to respond. Then you have to figure out what to do. So this is just a little quote to lighten the atmosphere. Which is just to say, there won't necessarily always be an easy and obvious, fabulous solution. If there were, you probably wouldn't have spent all this time that we've just spent trying to think about it. You do have to make some decision usually. So the idea is you try to make the best decision that you can. Sometimes this is framed as the least worst decision that you can. What you're trying to do is try to figure out what seems to be the solution that best reflects the values that you thought were important. And the benefit of going through a framework like we've just kind of walked through is to show that you've thought through it systematically. You've figured out what's important, you've thought about all of your options, and you've picked the option which seems to be the most justified. And that can be of really good support to you as care provider, as managers, as senior leadership, to be able to say, this is why we made that decision. We went through this process, we went through this sort of systematic thinking, and this seemed the most justified. And it can help you feel reassured that you did the best you could because you looked at the options and this seemed to be the best one and there wasn't a better one, at least that you knew of at the time. So it can be quite supportive in that way. So this is a little bit of summary. So identifying values can help to clarify the issue and guide your action. An ethics framework gives you a systematic way of analyzing the situation and achieving a justified resolution. For substance use, which we talked about, the job there, the important job, and especially in terms of the risk, the facts, the collection of facts at the beginning, is to weigh the risks to the resident and others against the individual's liberty, and to do what you can to try to mitigate risks where you can. Sometimes you can try to dissolve that tension a bit if you find ways to reduce the risks to make it safe for everybody, as safe as you can. be aware of personal judgment. As healthcare providers, we're sort of trained to keep recognizing that you have your own values and opinions, making sure you acknowledge those so that you know what they are and know when they might be coming into your workplace, trying where you can to keep those separate and focusing on what your obligations are as a healthcare provider, and get support that you need when you're in a difficult situation and you are experiencing quite a lot of distress. And again, the ethics committee is available. So normally you would go through your manager first in Bethany and try to see if there are existing resources to support to address the issue that you're struggling with. But the ethics committee is there for those more complex situations where a multidisciplinary perspective can help you, and where you'd maybe like kind of a larger group helping you think through it and giving you some advice. So that resource is there for you as well. So that's maybe the end of the official part of this, where we can say goodbye to our recorded people. I'm very happy to continue any discussion with anyone in the room if anyone has further thoughts and questions. So thank you so much for having me, and thank you for your attention.